I do want to introduce Dr. John Grant. He's a professor of psychiatry and behavioral neuroscience at the University of Chicago that you see there on your screen. He directs a clinic and research lab on addictive, compulsive, and impulsive disorders. Dr. Grant is the author of over 400 peer reviewed scientific articles. 15 books, wow, and the editor in chief of the Journal of Gambling Studies. And if any of you were able to go to I think it was March a couple of years ago, Dr. Grant, you spoke at one of our big seminars that we had in Raleigh, North Carolina. I really enjoyed your talk, and I don't mind saying I reference you, but I love to pull some lines from that talk about when you speak about young adults and gambling and the frontal lobe. I just remember that talk. But anyways, without further ado, it's all yours, sir.
Thank you much.
Uh,
And thank you for everybody who has come today. It's always a pleasure. I know it's a little bit always different, although maybe we're getting used to it with these virtual platforms. Um, I'm going to be going through a lot of information, and we could spend a day or two talking about the details of treatment. So, people, you can feel free to email me after the talk, or there'll be a time for questions, of course. But if you want more information, and I can give you references or the books that might be helpful for a deeper understanding of some of these things. But the good news is that there are actually a wide range of evidence-based treatments for problem gambling. And so sometimes when people are treating folks with this problem, they're like, oh, whatever I'm doing isn't working. And I would just sort of say, branch out a bit, see what might also be available that has evidence for it, and that might kind of philosophically fit with what you're doing. As you may find that you can help different people with different approaches, of course. I show this because I love this slide. It goes back to the 60s, and it does highlight the many of the issues that we need to be thinking about when we think about treatment, and kind of when we sort of see folks with this problem gambling, sort of what goes through our mind. And the reason I highlight this is two very important pieces of this puzzle are the comorbidities. And as you can, as you probably are well aware, drinking is one of those comorbidities that often needs to be addressed. Although usually when people really have a real difficult time with gambling, it's interesting that alcohol may be something in the past. And I've learned over the years, many people say, I drink less when I gamble because it kind of makes me feel dumb and I need to feel sharp. And that may be why then the second piece here, that cigarette that you see on the right-hand side, tends to be the most common current comorbidity in the addiction world that we see with people with gambling problems. People really feel nicotine can help sharpen their cognitive skills, and whether that's true or not, and for some people it is maybe somewhat true, just as a stimulant. But it doesn't make them a better gambler. We know that piece, but they may feel that they are. And these co-occurring problems, if they are current, like any co-occurring problem, really can be dealt with. Just kind of to jump to the end of that, can be dealt with concurrently with their problem gambling. People always say, oh, well, how do we sequence treatment? There doesn't seem to be really any need to do one first, then the other, then the other. That they can be done at the same time, because largely much of the CBT, of the cognitive behavioral therapy skills, and other types of psychosocial interventions that work for gambling are sort of largely borrowed, let's say, from the addiction world, so that we actually find that the same techniques, the same cognitive aspects can address both simultaneously. And we do know, and I've said this before at talks, but I'll say it again because it does need to be repeated, I believe, that people who currently smoke, if the smoking is not addressed, it has been shown to be a very strong predictor of relapse to gambling in people who have successfully stopped gambling in therapy, meaning that they stop therapy, they do well, but they're more likely to relapse if they continue to smoke. So it is important to get that under control as well. I would say that, as I'll mention other comorbidities a bit, if bipolar or manic depressive illness is a comorbidity, then it is important to probably address that one first, because that can get in the way of successful treatment for gambling. but not the other addictions, generally speaking. Also, I just love this slide. It's kind of, it also highlights this question. I mean, we've been talking about this now for what, almost 60 years. This is 60 years ago, and people were saying, why do people bet so much? The why we're not always sure of, and it could be quite different based on the person sitting in front of you. But now, as opposed to 60 years ago, we have better treatment approaches. I want to just highlight the criteria for gambling disorder. You're all well aware of these probably. The fact that people need 4 of the 9 symptoms. I put illegal acts in not because it is a current symptom of for diagnosis purpose, but it does suggest when we see people who've committed illegal acts due to their gambling, it does suggest a more extreme form of gambling disorder, and therefore probably will necessitate longer treatment and or maybe even more intensive treatment than we would do for somebody who has not done illegal behaviors. Most of the treatments I am talking about today are for anybody with a gambling problem. Again, you may just need to sort of think about it in terms of length of treatment and perhaps intensity of treatment if the illegal acts is a piece of it. The reason it was taken out as not needed for diagnosis is by the time people have committed illegal acts, they've already met enough of these other criteria. And it does speak to the desperation of people often with gambling and perhaps even some more antisocial traits of people, which means it may just, again, need to be more intensive. So what are some clinical aspects of addiction that we see across the board, but see highlighted in gambling? This repetitive or compulsive engagement in the behavior, a loss of control, an urge to engage in the behavior, although not always, but often. People will often get a very strong pleasure from gambling. And when we do a functional analysis as part of psychotherapy, part of it is to understand what are the triggers, but also what are part of what people are getting from it. Is it that I'm being triggered to gamble because I'm not finding pleasure in anything? And the pleasure of gambling is what is driving my behavior. And that functional analysis will give us a lot of information, what I would call about the heterogeneity of the behavior. Now, we know a little bit more about that from research, but people have known about this for decades, that the triggers can be different, that one person might have one trigger that's been the same trigger for their gambling for decades. Somebody else might have 10 different triggers. And the responses to the gambling behavior may all be different. Some people develop tolerance to their gambling and they've increased the amount. Some people have withdrawal. Some people have greater or less impairment due to the gambling. Some people come in for gambling not because their lives are falling apart, but they will report they hate the loss of control. Other people come in when they've hit rock bottom and they've lost their job, their loved ones, etc. So all of those, even the consequences of gambling, which does become a part of our treatment plan, differ based on the person sitting in front of you. And I just mentioned the other aspect, it's called telescoping, which we see getting back to that picture. Women tend to start gambling later in life, which is actually sometimes very useful. So they've often had aspects of their life that are more solid, that are more sort of healthy, whereas men tend to start gambling earlier on in life, usually around late teens, early 20s. But women tend to progress very quickly to a gambling problem when they start, which is why it's called telescoped, meaning shortened. Whereas men might have gambling behavior for 8, 10, 12 years before it meets all of those criteria. What does that mean in terms of our treatment approaches? It means that if you see a woman who has some type of gambling but may not meet full criteria, a problem gambling, she may progress very quickly and therefore interventions are more useful. As soon as we can get them started. In young men, the gambling may go on and it may be a part of multiple impulsive problems. They might have a little bit of problem with gambling, a little bit of a problem with drinking, etc. Now, there is less evidence for what we do with people who may only meet a criteria or 2 of gambling disorder, but even psychoeducation about for that young male particularly might be very useful to help sort of thwart some of the future development of gambling problems. I'm just going to briefly mention biology because it does help us, particularly with pharmacological interventions. Keep in mind that gambling is not a part of the brain that's unusual, meaning if somebody says, oh, do I have a gambling problem? Take a picture of my brain. I'm not going to notice like a big tumor, like a gambling tumor that's causing it. It's the same circuits of our brain that we use every day for all of our motivated behaviors, for eating, for intimacy, for any type of reward, for competition, all of these things that we take account of every day to make decisions. How much do I want something? How much can I resist it? How do I think of the benefits and the possible negative consequences? And we make those decisions. What happens in folks with gambling is that that circuit is hijacked by the gambling behavior. However, it does not mean that the same parts of the circuit are the same in 5, 10 people with gambling problem, meaning some people really love to gamble. And the desire to gamble is so strong, it overrides any of our good, healthy part of our brain that says, hey, there are negative consequences. Other people don't even really desire it that much, but they don't think of any consequences. They can't, they don't have any ability to put the brakes on any behavior. It's kind of like the potato chip test. If I have one, I need the whole bag. Other people, that decision-making process can be perfectly fine. And their response, when you sort of say, well, you realize there are negative consequences. Of course I do. I don't really even desire it that strongly. Well, then why? I don't care. I just don't care about anything in life. Now, that could be the I don't care of depression, or it could be a deeper sort of stress response that under any kind of stress that they've given up and they will just look to any safe harbor of zoning out, even though they know logically that the gambling leads to consequences. Why do I say any of this? Early on, the first treatments for gambling were actually these cognitive treatments, and they still work for some people. But the cognitive treatments, and they were developed by Bob Ladouceur in Canada, and they were genius. But they were based on the thought that people who have a gambling problem don't understand that the odds are against them. They believe that they can sort of manipulate the odds and win even when they're playing games of chance. So the therapy was really helping people understand, do you understand the odds? That when you play this game, the chance of winning is 1 in 800, right? I mean, and so he went through and tried to really educate people about probability. And that did help some people with gambling without a doubt, and it still does. However, it was based on the thought that all gamblers were the same and that they were all thinking about the odds of winning incorrectly. And what we now know is that this circuit of understanding of our desires and our behaviors might be off kilter. I might, if I have a gambling problem, have a problem with understanding decisions, but you might have a different idea that yours is about, I just want something rewarding. I don't, it doesn't matter what it is. And gambling is just a piece of that. And so understanding that heterogeneity has allowed us to tailor treatments better. The other piece about understanding that brain and the neurocircuitry of it is that we do understand that one of the criteria for gambling, and it's important from a treatment standpoint, interestingly enough, is that the role of Parkinson's and what medications might do to people started 20 years ago or so, allowing us to understand this chemical dopamine in our brain and understanding that certain medications can rev it up and make us want things more than we should want them from a health perspective, right? So that I kind of like gambling, but boy, when I'm on my drug for Parkinson's, I really want it. And so the criteria for gambling even says, make sure the person isn't taking a medication that could make the gambling either worse or make it such that that was the only reason that they gambled. And so we realize that this is very complicated. It has a lot to do with maybe our genetics, etc. But it's always important to start treatment with people sort of saying, look, even if you're not a physician, what medications are you taking? Because those may make the gambling worse, or even, for lack of a better term, be the reason you're gambling. And those could be medications for Parkinson's, they could be medications for restless legs. People have suggested that aripiprazole, also called Abilify, which is an antidepressant used for mood stabilization as well, might also result in gambling problems. Stimulants that are used to treat ADHD might also make it worse. So I've seen some people that you can stop the medication and the gambling just goes away. They don't even need any formal treatment for gambling specifically. So it's just one piece of the puzzle to be aware of. And as I said, what we're trying to understand is when people gamble too much, it's this expressed behavior. Gamble, gamble. It could be anything. But underneath it is our decision making and our thought process. Why do I do what I do? How do I make those decisions? And below that are understanding brain abnormalities on brain scans. That's not really ready for prime time in the sense that I can't look at one person and say, oh, this is necessarily what's going on with you. But neurocognitive, neuropsychological testing is being that middle ground can tell us a lot about people. Now, not everybody can afford that, and insurance doesn't always cover it, but it can give us real clues into what we can target more effectively in terms of our treatment. And this is why neurocognitive deficits in all addictions, but also in gambling, we see problems with planning in some people, planning for the future. They don't think about the steps down the road. We see problems with flexibility in some people. We see difficulties with inhibiting behavior. And these can all be very useful targets for therapy, particularly on a cognitive behavior therapy level, if you know what the deficit is. Now, that can be done through simply really detailed discussion. Sometimes we'll give you clues, but it can also be done through doing more thorough neurocognitive assessments with people. And what we found is, even though historically gambling was considered an impulsive problem, well, these people don't think, they just act. We now know that there are aspects of being very compulsive, being fear-driven in it. We used to think of these two as different things, and now we know that there's a blending of these. So some people can be very highly impulsive and very highly compulsive both. And we also know that the illness of gambling probably changes over time. So that somebody who's starting in gambling might be very impulsive. They're very, they're making rash decisions and they do it without thinking about all the consequences. Whereas somebody who's been gambling 30 years might be very compulsive. They're very fear avoidant. They do it almost very ritualistically. It may almost look like an obsessive compulsive problem. And in between those people, it could be any kind of mishmash with other aspects. What does this all mean? It means that our treatments may need to change based on where in the course of an illness somebody is. Are they early on in their gambling addiction, or are they later on? That may be two different treatments because it might be two different qualitative circuits in the brain, i.e. illnesses. And that becomes very important. And this can also be, again, often kind of ferreted out, if you will, through a detailed functional analysis. So what does all this mean? So on to the treatment. What we know is that people with gambling problems, like many addictions, are quite ambivalent about treatment. So part of the treatment approach needs to be aware of that ambivalence. People will call me in the middle of the night, leave a message, because I don't pick up my phone in the middle of the night, but they'll leave a message and they'll say, I need treatment, I'm coming home from the casino and I've lost everything. I could call them back the next day, and once they realize, okay, their spouse didn't leave them, maybe it wasn't as bad as they had thought. Now they're like, well, okay, I'll call you if I need you. I don't really need treatment right away, right? We get this push and pull. I'm in a desperate state. Now that can speak to coping deficits, which can be dealt with through psychotherapy, but it also, and the impulsivity that we see, not only the impulsivity of gambling, but the impulsive, I need a treatment, I need it quick, and I need it now. And even that impulsivity can lead to ambivalence. I want a treatment, but I don't want to be in treatment. I just want something quick and, let's get it done. All of that needs to be a part of the assessment, of course. What the expectations are, how much of an open door policy a person is willing to provide. If somebody drops out, will they come back? Is it okay to come back, etc. But there is an enormous amount of ambivalence about the behavior. And as we know, it's because it's very rewarding. People enjoy it. They might find that it helps them zone out. And so there are things on the plus side of the ledger sheet. Motivational interviewing often is very helpful as an evidence-based treatment approach. As many of you are well aware, it's worked for other addictions as well. And it's been shown to be very beneficial, particularly for that ambivalence that people with gambling have. Gamblers Anonymous. It's a long history since the 1950s. What we know from Gamblers Anonymous is a couple things. It's a bit complicated. Some people, testimonial evidence, people do very well in it. Data-based evidence suggests that people don't stick with it. It's got much less of an attendance than, say, Alcoholics Anonymous. We're not sure necessarily why. There are lots of sort of theories about it, and some evidence that perhaps it skews a bit older. Younger people don't like Gamblers Anonymous as much, all of these things. But what we do know is when it's compared head to head, and I'll show some research, individual therapy tends to do better than Gamblers Anonymous. But what we know is also people who are engaged in Gamblers Anonymous tend to stay in individual therapy to a much greater degree. And people who are in individual therapy tend to sort of then find that they will stay in Gamblers Anonymous to a greater degree. So it tends to work synergistically with the individual psychotherapy. There are fewer sort of outlets, meaning there are fewer meetings than, say, Alcoholics Anonymous, but they're out there and they're available around the world. As I mentioned, the dropout is higher. So most people with gambling problems may only attend one meeting. Very few people follow through on a regular pattern to earn a 1-year abstinence PIN. And those rates are lower than, say, what we see with Alcoholics Anonymous. They're higher. Good news is that they are higher than what we might see with stimulant addiction or cocaine addiction. And it's often, again, the realistic expectations of it. It's not a quick fix, but that's the case for individual therapy as well. Now, many people who did drop out they would say endorse a controlled gambling. Now, I should say that part of treatment, any treatment that people engage in, is what the goal of treatment is. Gamblers Anonymous has focused on an abstinence approach based on sort of a 12-step model of abstinence, etc. We do know that some people may come into treatment and want a controlled gambling approach. Is that unrealistic? No. Some people can develop a controlled approach to their gambling. Here's the upshot, though. As of yet, we don't have good predictors. If Bill Smith comes in and says, you know what, I want to get my gambling under control, I might say, great. I don't know if you can. Now, we don't know, is a 50-year-old guy who's been gambling for 30 years, is that the person who's most likely or less likely? We don't know that. What we do know is that many people who say they want controlled gambling, at least in psychotherapy, ultimately switch to an abstinence approach, probably due to ease of a bright line rule. Having said that, some people can. Again, we just don't know who can and cannot do a controlled. And I would say that's the case for alcohol too. Some people can have their alcohol use controlled. It may be a minority of people, but again, we sort of lack some of the predictors to know, to be able to say, look, based on everything you've told me, it's not going to work for you, versus somebody else I might say, okay, you might have a chance, right? So again, what the goal of treatment is, and it may not be what we necessarily believe the goal should be for them, but taking them where they are will at least keep them engaged in treatment, and then that goal could change, or our perceptions might change as well. Gambling has self-exclusion programs at most of the uh, actual physical casinos, card rooms, etc. What we know about the self-exclusion programs, I should say, is that from a therapy standpoint, they're a very useful way for the therapist to determine what the sort of commitment to treatment the person has, right? So if I say, wow, look, you go to that one casino, you could exclude yourself. And exclusion programs differ a lot on the casinos or the card rooms, etc. They could be from 6 months, a year, 5 years, or life. But when you mention it to somebody, um, if their jaw drops and they're like, well, what? I don't want to exclude my right. They may not, it may be inconsistent with what they're telling you when they say, hey, listen, I really want to quit. Well, do whatever it takes, no matter what. And you're like, well, start maybe by excluding yourself, and then like, hey, I don't really want to do everything. Right. So I think the key about it, so it can be useful, not as a fail safe program at all. It's just part of information I believe a therapist can use to sort of check motivation, etc., and commitment to stopping gambling or getting it better controlled. I think the self-exclusion programs, they'll become very important for family members. When somebody is in treatment, if you have access to family, sometimes family feel that these programs will prevent their loved one from gambling. So they're like, oh, I don't think we have to worry anymore. That, my brother's he's self-excluded himself, so he should be fine. And as you well know, depending on the casino, sometimes the smaller ones, the tribal casinos, they're not well monitored. They're not set up sort of through technology to monitor everything. And they are not a be all end all terms of stopping the person from gambling. And because of the lack of sort of coordinated programs, excluding at one casino, you can walk across the street, it's owned by somebody else, you can gamble there. So it's not a fail safe program. And some family members have sued casinos when when their loved one has been excluded. Those have largely not worked for family members or the gambling person. So I think that they're just another little bit to help the person, a speed bump, another little speed bump that helps the person not be able to maybe go to the place where they usually go. And it can be very therapeutic to, again, as I mentioned, to see motivation to stop. Now, there are multiple studies of all sorts of psychosocial treatments. The majority of the treatments, of evidence-based treatments, are some form of cognitive behavior therapy. That's a broad umbrella often for many types of psychotherapies, I should highlight. And generally, there's a lot of sort of similarity across these. There is sort of still this idea of understanding irrational thought process. Oh, my lucky socks are going to help me win, right? I mean, realizing that there is no logic behind that, and to restructure people cognitively. So there are some key elements across all of the types of cognitive behavior therapy, understanding triggers, and then developing healthier behaviors. But when you hear about it, if you read, and there are treatment manuals for people who are interested, you can get a treatment manual and you can sort of see how they take the client through the process. You can use it strictly, rigidly, or you can intersperse things that you are already doing that the treatment manual may not have. But if you look at the treatment manuals, like, wow, they're kind of different. And it's because people have developed different types under that rubric of cognitive behavioral therapy. One of the things, too, that has been a bit of still a kind of a big question mark is how much cognitive behavior therapy. Some of these treatment manuals and studies that, and the reason I mention these is because we have ways of controlling, right? When if they've been rigorously studied, meaning they've often been compared to doing nothing, they'll be compared to just a supportive psychotherapy, or They'll be compared to, say, Gamblers Anonymous, etc. That rigidity about the approach, often then being assessed by somebody who's not delivering the therapy, so the person hasn't had a vested interest in it. Now, that doesn't mean that there aren't tons of treatments out there that people do that might be successful. And I'm always interested in hearing about those. What I'm talking about is the things that have been rigorously examined in controlled settings so that people are just assigned to a treatment and we see if it works. Um, the still, having said all of that about these treatments, we don't know exactly how much therapy somebody needs. Now, as I said, if somebody has maybe some illegal behaviors, we tend to think more, 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 but more is not a number, right? More than what? And it may still mean that the person needs extended treatment. But many of these psychosocial treatment studies have seen incredible benefits that last long term, years down the road, meaning the person quits gambling and they stay quit by doing anywhere from, most of the studies, 1 to like 4 months of therapy. Now, some people are like, wait a minute, why not longer? What about people who are in therapy for 2 years? Now, it doesn't mean that that's not useful for some people, but just in terms of looking at the gambling piece, they might not need 2 years. That person may not have needed 2 years. Now, doesn't mean that 2 years isn't helping rebuild their lives and all of these things, which don't get me wrong, is terribly important. But just looking at the gambling behavior and getting that better controlled might be helped in as little as one session, what we call brief interventions, or it may need weekly sessions for several months, maybe up to 4 months. What is intriguing about some of this is some people who have severe gambling problems, maybe not the illegal behaviors, but still a lot of other problems, can often do very well with brief interventions. And that may seem counterintuitive to many people, thinking, no, if I have a problem, I need more, more, more. Well, maybe they don't need more. These treatments allow the person to do a lot of the work on their own. They give them homework assignments. So the person is doing therapy on their own, but they're learning how to be their own therapist. The treatment is giving them the skill sets that are necessary. Now, that doesn't mean that everybody catches on as quickly, but some people do. My point is that sometimes people will go to 4 or 5 sessions and then we never see them again. Now, sometimes we think, oh, they've dropped out, they've gone back to gambling. I'll tell you, I contacted many of my patients over the years who dropped out after a few sessions just to find out. And I was surprised how many people said, I'm doing great. I got what I needed. You gave me these skills in these first few sessions. I continue to use them and I'm doing great. I didn't know that there was more that you wanted to do, right? And so, we have to also be aware that what we think is necessarily useful for everybody may not on the individual level be necessary. I always kind of developed a treatment program and I thought, okay, the person needs at least 12 sessions dealing with all these things. Wait a minute, what do you mean you got better after 4, right? I mean, it seemed kind of like, look, you're missing out on, I got 8 more sessions for you. They may not have needed that. And so we're continuing to work on who can do well in sort of shorter sessions or who does well needing longer treatment. And other than the illegal behaviors, we haven't seen a lot of predictors who needs less and who needs more. As I said, sometimes it's about what we do may be more important, than how much we do. So the cognitive behavior therapy, again, as I mentioned, it starts with psychoeducation, which cannot be underestimated the value of just education around a problem. Having people understand this is, this is the gambling disorder you have. This is why we think it was developed. This is, what's going on in your brain. Sort of the psychological, philosophical aspects of this, etc. This can all be incredibly useful information. And then having the person become aware of how they think. Okay, and even some of the irrational cognitions aren't even about the gambling, but they can be about the triggers. I'm upset. It's a Friday night. The only way I can calm myself down when I'm upset is to gamble.
Well, that's irrational. There are many ways. It may be the only way I feel that I can, or that over time I've come to believe, but it's clearly not the only way that a person can calm down, right? There are millions of people out there who do not gamble when they're upset. Therefore, what do they know that you have forgotten or didn't know? And to have even people recognize, the framing, the restructuring of it. Does gambling really calm you down? Short term, maybe, but then you come home, you're broke, all of this sort of stuff. Now you're upset again. Maybe part of that stress that you're feeling is due to the gambling, ironically, right? So having them understand, you know, what drives what, all the irrationality can be incredibly useful. And then any number of triggers, and then what they can do in a healthy way to decrease the triggers and or cope better with those triggers. And this is a clear, as many of you know, when we do cognitive behavior therapy of any sort, a functional analysis to understand the triggers, the thoughts that the triggers elicit. I'm alone on Friday night. Oh, I'm so unlovable, I'm unattractive, etc. The gambling makes me feel, that I'm special, that I'm powerful, that I'm, in control of things, etc. And then the consequences. And both the positive and the negative consequences. And one can extend this out then even further and recognize other healthy options that could be in place of these, as you recognize how the thought, the trigger leads to a thought that leads to a behavior, and that you can intercede at various points in this to show healthier alternatives to the way I'm thinking and what I'm doing. Group therapy also is an evidence-based approach to gambling, largely a type of cognitive behavior therapy in a group format, using cognitive restructuring, using coping skills, understanding triggers. It can be done with any number of pieces, even using exposures, as I'll talk about in a bit. But groups can be very helpful, again, using largely a cognitive behavior type of therapy, because of many of those cognitive distortions are similar. They're unique qualities about every gambler, but some of the same distortions, the same triggers find a home with many of them, and that will resonate at the same time. So these are being done around the world. One of the leaders is actually, interestingly enough, in Brazil, that have developed all these kind of group formats. Again, the groups don't have to last a year or two, but weekly group therapy for maybe 4 to 6 months might be what people ideally need. The groups may be a little bit longer than even individual therapy because of the lack of some of the individual attention, but the same types of treatment can be done effectively from an evidence-based approach in a group format. I mentioned the brief interventions, and these also usually are types of some type of cognitive behavioral intervention. They have run the gamut, meaning a single session could be a brief intervention, a single session of education followed by giving the person a workbook, having them work through therapy on their own with maybe some check-ins by phone a couple times, motivational interviewing, a couple sessions of that have been considered a brief intervention, and even doing reading on gambling and gambling problems, etc. So, the workbooks of brief interventions are largely, as I mentioned, a CBT or a motivational interviewing. And motivational interviewing has its own obviously cognitive therapy piece. So it sort of falls under that umbrella as well, depending on how broad one defines the umbrella. And so these can be done, and they've been compared to waitlist, meaning just people doing nothing. And they've been shown to be helpful. And some of the brief interventions have shown to be beneficial years later. Now, some people would say, look, these might be helpful, but they're helpful for people who have a really mild problem. Like doing 1 or 2 sessions with a therapist isn't going to work for people who've really lost everything. Well, that may be true for, to some degree. Although the brief interventions have been shown, depending on how one defines severity, number of symptoms, number of financial difficulties. They've been shown to be helpful also for those who are moderate or more severe gambling people. So it doesn't only apply to the mild folks. It can also apply to the more severe people. Why some people gravitate toward kind of doing something on their own using a workbook, it may be have a lot to do with just where they are, right? One of the things I should just put as a footnote to this, keep in mind about 20 to 30% of people with a gambling disorder also go through what is called natural recovery. Not with GA, not with the use of priests and religious help or therapy. They just stop on their own. We don't know a lot about these folks. They've been studied to some degree. People that after 10 years of gambling problems just say, I'm done with it, right? We've all known people like that with any number of problems, right? People who have been overeaters, smokers, alcoholic folks, right? That just say one day, I'm done. Now, and they do very well. They don't necessarily crave it. They're not struggling. They're just like, you know what? I'm done with that chapter of my life. We don't know what there is unique about those people. Is it just some sort of vague willpower issue? Is it psychosocial support that they have always had or didn't recognize before or have new to their lives? But what we find is maybe people with brief interventions that have done well are people who are already ready to stop on their own anyway. And the brief intervention just gives them a few extra tools to actually be successful. That may be the case. What that is in folks with natural recovery, I mean, again, the reason we don't know a lot is they don't seek help. They just live their lives. So it's been a little bit, and sometimes they don't even know. When I've talked to people, they just say, you know what, I just woke up and said, I'm done with it. I was just tired of doing it. Great. But tell me more. And they're like, I don't know. I just quit. So sometimes people aren't all that aware, but that harnessing whatever that is internally may be why for some people the brief interventions also are helpful, that some of these people maybe could have done it even without these interventions. Another type of cognitive behavior therapy that is shown to be based in evidence are marginal exposure exercises. These are brought from the anxiety disorder world, where the goal of anxiety disorders is not to have people avoid what triggers their anxiety, but quite the opposite. Let's expose you to it, but we do it in very graduated ways. So we do a little bit more, a little bit, etc. And you learn how to deal with the anxiety until it goes away. And you employ cognitive skills, some behavioral skills, but you kind of sit with it, so to speak, and then it goes away. You kind of desensitize. And so folks in Australia 40 years ago started using this. I use quite a bit of this as well. Other people have sort of reinvented it, so to speak, in a variety of ways. The idea is, okay, let's expose you to those gambling triggers, loneliness, billboards for gambling, if it's a visual trigger, whatever the trigger is. But we do it not by having you actually experience it, but doing it in your imagination. And therefore, then you learn how to cognitively think through it, cope with whatever the urge is to run to the casino, to escape, to feel good, to feel a rush, whatever that is. Learn how to do it maybe in other ways, but to sit with the trigger and realize it goes away. It may take a while. You may need to employ a variety of skills, but you can deal with the trigger. That was done because some people would say, I can't get away from these triggers. Friday night is my trigger when I'm home alone. I'm always home alone. Well, then it's, we can't keep busy every second, but how can I then have you relive that so frequently, not just on Friday night, but multiple times every day, so that you become desensitized. And this has been shown by doing this in a few sessions, 4, 5, 6 sessions, that these can be long lasting for many years. And so the folks in Australia did it. And as I said, they've been reimagined in many ways. And it can be done safely without triggering people to worsen their behavior. This is just a form of what an exposure exercise might look like. Because of time, I won't go into it. People can look at these slides on their own. And when we've done studies compared to Gamblers Anonymous, the people that improved using this type of imaginal desensitization exposure with some motivational interviewing, now 6 months later, they were still doing well. And now, even several years later, the numbers are about this high, still high 60%. The reason you don't see Gamblers Anonymous later is everybody was offered the treatment and they decided to take it. This is motivational interviewing. It can be used for all of these types of behaviors, gambling, eating, sex, anything, and it's been used for substance use. And it's a systematic approach to motivational interviewing is its whole type of therapy, but this is just a homework that can be incorporated into any type of therapy to have people work through the ambivalence. But what you're also seeing in this is they're working through the cognitive distortions about what are the positive aspects, right? It's helping them recognize that. People do gambling for a reason. People say, oh, no, it's all bad. It's all bad. That's not true. It may feel all bad, but there must be something positive, at least one point that you got from it. Otherwise, you wouldn't have done it, most likely. And that's important because whatever that positive is, that also gives me clues in terms of what I'm going to maybe help you brainstorm healthy behaviors that might take the place of it. If you love risk taking, if you love excitement, then we need to think of healthy behaviors that can sort of approximate what gambling was doing. May not be the same completely, but at least maybe approximated. If you love escape and you just want to get away from stress, then the behavioral intervention, and that's the positive aspect, then the behavioral intervention can use that by helping you brainstorm other different options. And I should say also, as many of you are aware, in the substance field, contingency management has often been very successful for drug and alcohol problems, meaning that you may get rewards for a negative urine, right? You may get vouchers, you may get acknowledgments from groups. You may get even prizes or the chance for prizes by having a negative urine screen if you have a drug problem. This has been used in the field of gambling as well. And I should say that even using prizes, and people say, well, that's kind of gambling, isn't it? Nancy Petrie now 15 years ago found that contingency management when part of psychotherapy and rewarding people for, say, going a week without gambling, going another week without gambling, even with prizes, did not engender or trigger a gambling response. Even though it might look like low-grade gambling, it did not feel that way to the person because it was part of a psychotherapy program and it was being done as a reward, a healthy reward for somebody. And wasn't, money as as the prize, but maybe, prizes to treat oneself to a dinner out or something like that. I should also say that those are sort of the big groupings of the psychotherapies. And just in a couple minutes that I have, I just want to talk a smidgen about the medication piece. Again, what we don't want are people thinking about medications as an easy fix. That gambling tends to affect all of these other aspects of their lives. They may have other co-occurring problems, as we've talked, but medication may help with some people with gambling, and there's been a wealth of data on it as well, although no medication FDA approved yet by the Food and Drug Administration. But those medications that are often used in other addictions, particularly opiate antagonists, which block our desire or dampen, I should say, our desire, say, to drink or to use opiates, have been successful in the treatment of gambling. And that would be largely the medication, old oral medication, generic naltrexone, which we started doing research back in the last century, in the late 1990s. And it was helpful to decrease urges. Didn't maybe eliminate them, but decrease them in many people who had a gambling problem. And that has been shown in repeat studies over the years as well. Another option which has gained some traction in the substance addiction field is a vitamin, which is N-acetylcysteine. It's talked a lot about on the internet. Part of the issue I would caution is that vitamins are not quality controlled. So there is a question about how well one brand may work over another, and that's just been very difficult to really understand because these brands are not controlled by the FDA, vitamins aren't. But the Medical College of South Carolina found that N-acetylcysteine, because it works in that reward center of our brain, that circuit, that part of the circuit that says go, 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 has been shown in the case of cocaine addiction, marijuana addiction, and smoking actually, to decrease those urges by using this antioxidant, which is available over the counter. We looked at it in gambling in folks and found that it was quite beneficial. And this is a score of total gambling behavior and urges. And it was able to decrease behavior and urges by at least 50% after only a few weeks taking this vitamin. And then when we switched people to whether to stay on it or take a placebo, you notice that people who took placebo got worse again. And so this may be we've used it with psychotherapy as well, because it does tend to cement cognitive behavior therapy in gambling disorder. I should just highlight other things that have been studied, memantine and Alzheimer's medication, because it helps with decision making in young people who don't have Alzheimer's. It's perfectly safe in people, but it may help with impulsive decision making. And this is a slide, a lot of detail that because of time I won't go into, basically showing that people with gambling problem had problems with flexible understanding. They get stuck. And when they were treated with this Alzheimer's drug, their brains looked just like people who didn't have a gambling problem. We've also looked at it in other types of cognitive enhancing drugs that may be helpful. And this is just a slide showing that you could even look at your genes maybe as a way to show who would respond better. I was going to talk about a couple cases, but I'll just highlight one case because this is a young person who had gambling problems. He worked in a bank. He ends up stealing from the bank to pay off his gambling problem. He was court ordered. He didn't really have any other issues, although cognitive testing showed he almost had like an attentional problem, an ADHD problem with some impulsivity. And I highlight that because we do see some folks with gambling problems who will say, I have ADHD. We need to be very cautious about using stimulants in people with a gambling problem, because if they don't really have ADHD, the stimulant can make their gambling 10 times worse. If they really have ADHD, the stimulant may actually help with the ADHD and the gambling. Part of the problem is that, what do we mean by really have it? It's based on a lot of testing, talking to their parents if they're adults. People may want to believe that they have it as an explanation, and therefore the medications may make it worse. So even though we may talk about medication options as possibly helpful, we also don't want to use a medication that might make a gambling problem worse in people. So, and we all need integrated care in gamblers. I talked about the evidence-based for the specific gambling problem because that's what's been studied, but we know that there's a lot of public health issues that need to be addressed. Health problems, divorce, other mental health, financial, economic, legal problems, co-occurring other problems, mood disorders, anxiety disorders. Suicidality needs to be addressed in everybody with gambling. Because of the high rates of suicide, even at lower levels of gambling. It's not only the person who's lost everything. It seems to be tied at all levels of gambling, and it may suggest also its own impulsive problem. I need to kill myself because that's the only way I think I can deal with it, and I need to get rid of this feeling immediately, right? That same impulsive decision-making might be at work. So this is where one, right, as I mentioned, I want to move on to any questions, but you can sort of see, we start with what's the evidence-based for the gambling problem in particular, but when a person's sitting in front of you they're obviously much more than just a gambling problem. And that's why that larger integrated understanding of all of these other things, even though the gambling treatment may be a short treatment, meaning X number of months, all of those other things may necessitate longer term and referrals to other specialists, depending on what the problems are. So I know, short period of time, lots to talk about when you talk about treatment. So I'll open it to questions, whatever people may have.
Thank you, Dr. Grant. Very informative talk, and it is a lot to get in an hour. And but I really we enjoyed your perspective, and you're getting some praises here via chat. We did have one question earlier from Barbara and Rita about what you suggest as far as treatment manuals. Have you written one, Dr. Grant? I'm not
I
sure if you
do,
have,
but I
but
don't
what
want
would
to
you
put a
suggest?
plug in.
Okay.
My
Yeah.
treatment manual is about impulse problems, and it specifically will show you how to do imaginal exposures. Other treatment
Mm,
manuals that are very helpful, Nancy Petrie, who's no longer with us. She passed away a few years ago from cancer, but she had a lovely book on gambling. And in the back of the book had a delightful and incredibly detailed, just basic cognitive behavior therapy manual. No imaginal
mm,
exposures, but that type of manual. Bob Ladesseur, as I mentioned, has a manual as well. His is largely the cognitive piece, less on the behavioral side, but a really detailed cognitive therapy manual. So it a little bit has to do with kind of your philosophical bent. They're all
mm.
helpful. They've all been shown to be evidence-based in the big broad picture, but you may find that depending on what you kind of gravitate toward, philosophically and in terms of your own experience, may determine which manual is better suited for you. I will say of the three,
Wonderful.
I think Nancy Petrie's, just between us, is the best, and that is better than my
Yeah.
own. So, so for what that's worth.
No, wonderful. Thank you. And they also asked about you talked a little bit about workbooks too. Do you have any suggested workbooks as well?
So workbooks, David Hodgins' group out of Calgary has some workbooks that you can find online as well. The UCLA group of folks have a workbook that I believe is even free from their providers, and it's a very useful, again, a cognitive behavioral workbook. My manual has a therapist manual and a workbook associated with it. And so I think you can find any number of good workbooks out there.
Wonderful. Thank you. Yeah, we talk about it in our SureBet trainings, the UCLA handbook,
Yep.
but those were all great suggestions. And thank you very much. And thank you for your review on the imaginal exposure, desensitizing those triggers, coaching
Sure.
folks to lean into it. So it helps them. So I appreciate it. And again, I love your position, and it was nice having you, Dr. Grant. And I look forward to working with you, hopefully again. And
And feel free to also, my email's on this last slide. So if people want to email me, and if I don't get back to you right away, just keep pestering me. I will with whatever questions you have. So
no worries. There's one more question if you've
Mhm.
got a
Oh,
second
you bet.
from Barbara. She's just wanting a little clarity. It looks like from a contingency management being helpful for the person with problem gambling or who is diagnosed with gambling disorder. So problem gambling versus a formal diagnosis of gambling disorder.
Yes, I should say that all of these treatment approaches that I've mentioned are useful across the board, both at the low level, what we call the more sort of problem gambling, maybe a symptom or two, versus those who have full-blown gambling disorder. They look like they'd be helpful. And I would actually argue too that if we can get the treatment at the lower level of problem gambling, ideally we thwart the development of the later ones. So I think that, again, they may not need months and months and months, and they may not need the whole integrated piece because their lives may not have completely kind of have the sort of repercussions as a gambling disorder, but the gambling treatment itself can still be helpful.
Makes sense. It might treat it before it progresses into a
Yep.
diagnosable condition. Nice. Okay, everyone, please join us February 2nd with Dr. Rory Reed talking on coping strategies and problem gambling. Go to the UNC Behavioral Health website to register for that. Again, thank you, Dr. Grant. And this is recorded and the slides are at the UNC Behavioral Health website. Thank you very much again. Good seeing you.
Thank you.
Okay, have a good one.